And we're back. Welcome everybody to the Healthcare Quality Risk Risk After Show. We're talking about realizing synergy between quality and risk. We just finished our live topic just a few moments ago, and we're continuing our conversation now. If you haven't seen it, you can catch the recorded version here on our YouTube page or on our LinkedIn page. The link can be found in the description and comments section down below. So go ahead and get in there. Please let your friends know about the after show. All of our shows are out there on LinkedIn, so please dive in and participate. Okay, guys, we're talking about, we covered a lot of stuff already in just the 30 minutes of the live show. We were talking about systems a little bit and being disparate and being somewhat of a root cause. We talked about how systems often are driving process, which is a big no-no, right? You never let the systems drive the process. We're talking about how there is a big disconnect going on in healthcare organizations between quality and risk. Huge gap that led to a big incident of the month that you brought up, Rob, where a hospital was a leapfrog A rating and then got their knees chopped out from under them with a lab problem, and now they're wondering if they can keep the doors open. And
that's all it takes. That's one. Now it's in the paper. It's in the hospital report. They worked really hard to reach that A rating, and now that A rating is thrown out the door because the only thing the public hears now is, "Oh, hold on, if you go there, you are in jeopardy. You're in harm's way."
What I'd love to do in the after show is really dig deeper into how these issues are out there, and also how Aperitisoft Healthcare could have solved the problem, And, when I think about this, it's like, well, wait a minute, how could that have gone wrong? Well, if one, you are tracking all your incidents and monitoring all of your action plans and corrective action constantly and seamlessly in the system, something should have surfaced there. Something.
It's no way. So the lab standards are so prescriptive. Lab standards are very easy to follow because they are so prescriptive. Literally do this at this time every time. And they're crystal clear to be there's a lot of them, but they're very clear. For finding things like training deficits, finding things, there's like quality controls missing. There's finding things like staff training and testing oversight. So finding things like no quality management system evaluating the functions. Those would have absolutely come up in a risk assessment, in a proactive audit. Putting those standards into a system, and just, do we have it or do
Great example. I mean, do other systems do that? I mean, Aperitisoft can do that easily.
They have, some of them have a function where you can evaluate whether something exists or not, right? It's compliant or it's not compliant. But as far as like making it better and getting to a compliant point, no.
Okay.
And that's where the real gap is, right? And that's where quality really is working with compliance and risk. There's in a synergistic way.
Well, let's I'd like to explore this a little bit, Timothy. Let's explore this. So if say that somebody has Datix, right, and they did put in the standard, and they went through and they're like, well, based on our opinion, we comply with everything that's in there. Now, I don't know how Datix works. Would Datix allow for them to document evidence to that? I'm not sure.
Sometimes, yeah.
So if they would have that in there, but okay. So, and then it stops. Okay. And if there were some gaps, the system's not necessarily giving them an easy integrated way to go and fix the problem. They probably have to set up a separate set of action items somewhere in the system that would follow, that is not really talking back to the original assessment. Is that true?
If that. There's the systems that I have used from RL Datix or QPulse or Qualtrics, or there's Midas. Once you've identified something, you tend to, if you haven't bought another system, go to email. hey, Timothy, I just evaluated your lab. I see that there is no Aero Scout, so no temperature monitoring for your blood cooler. Explain what you're doing about that right now and how are you going to prevent that from happening in the future. I'm going to send that to you in an email. I'm going to wait for you to do your thing, which would be basically whatever you chose to do. With no structure to it, no cost associated with it to evaluate cost and quality. There's really no oversight. Wait for you to reply. Hopefully you reply. And then I'm going to go back into the system and some systems and say, I'm done. I've closed it out. It's now compliant. Or it just stays completely open-ended. And I would have to find all of those emails later to turn over to an auditor if they found the same thing.
So it's that manual process that we talked about earlier where someone unfortunately ends up dropping the ball. When it comes back to the human touch, the person that has to keep up with these emails, the ones that's tracking this information, it's likely that somewhere along the line, the ball just got dropped. And unfortunately for Missouri's hospital, I mean, it was something that was tragic enough to be able to end up on the front page of the news. So I think when you're looking at a system that should be able to do what they say when it comes down to tracking all of this information and being able to communicate it across the system, you really have to get down to the lines of where are the limitations? Is that limitation going to be something that's going to cause us to end on the front page of the news? I think that's just something that we have to keep in the back of our mind as healthcare executives.
Yes. What I find what's cool about Aperitisoft is that you could go in and do a pre-audit, Rob, right?
Proactive.
You can go in, do the whole thing, and beat up on yourself, right? Beat up on yourself. Be tough on yourself.
Be more strict than the rules.
Yeah.
And
then you put in your corrective actions. So let's say the audit happens anyway, right? Auditor shows up. A lot of, you can pull that up right away for the auditor and say, well, this is how we have documented our self-assessment. And they can say, okay, fine, I want to go look at this. I want to go look at that. They're going to walk around the hospital. They're going to be verifying things. And they're going to come back and they're going to give you an audit report, right? Now, what's cool about this is that you then could go in and create a new cycle for yourselves in the system, this time making the changes that the auditor says. So now the auditor puts it in, same assessment, but now rather than it being yours, it's what the official one was. And then now you put in the corrective actions that they said you need to do on top of the ones that you were monitoring already before. So now that's in front of you all the time, and you're managing these things to completion. Now, once this cycle begins, particularly in one particular standard, you can always have the last audit, and then the next go around, you do a new prescription on your own. You do a new review on your own, and you're doing this back. Think about the proactive perspective of that you weren't doing before. I mean, it's a big difference.
It's a very big difference. And you just reminded me of, and I can't believe we haven't brought this up before, in my infancy of consulting, I was working with this very tiny, hospital out west. And I did a readiness audit, for their certificate accreditation. So they were going for a specialty, there's accreditation, so a certificate on top of what they were already certified for. And I did the audit. I passed over all of my findings. They did not want to pay me to do anything else or have me involved. Just identify they were going to fix. I got a call from them 4 months later. They were cited for 60% of the findings that I sent them.
Wow.
So they had no systems in place. They thought that they were doing amazing things, which they were, bringing in outside support to help close some gaps. And they wanted somebody to say, here are the certificate standards in order for me to be certified as this. And I need somebody to tell me, am I there or am I not? Mm-hmm. And once I passed it back to them, they sent out an email. So the executive team fired off an email to the rest of the leadership, of this small little hospital, and said, please find what's yours and get it up to standard. Guess what they didn't do? They had no oversight. They had no quality feedback, no loop closure, anything. And every single person said, we're short-staffed. It's There's the middle of COVID. We're not worried about this stuff. And this is just not a thing that we're going to focus on because there was no accountability.
If they're going, go back to Aperitisoft Healthcare, of course, you create a CAPA, corrective action.
There, everybody sees it. You have deadlines.
You get the group to agree on what are the milestones that need to be achieved, right? You link those milestones back to the actual scoring, because that's the other thing you're going to get in Aperitisoft you don't get with others. It's not just saying you don't comply. It's going to give you a score, right? Down to the individual requirements that are there. So when you address them, you can start showing how your score would have been modified if you would have complied.
Oh, yeah. All they would have had to do is go in and put those milestones in off of what I sent them. And they could have had executive oversight as what is done and what is not done. And there was nothing in their report that was so egregious, so expensive, so unattainable that they could not have fixed inside of 4 months. There was a lot of missing policies. There was a lot of missing training. Those are very easy things to fix, albeit training is expensive. Staff hours to train, it's expensive. I get it. All of those things, though, were attainable within that time frame.
They don't appear to be so, but they have big returns on investment.
Huge returns on investment. And they could have seen that in a system like Aperitisoft Healthcare when they were like, oh, here's my cost of poor quality. Here's how much I reduced my cost of poor quality.
Well, think about it, Rob, too.
Go ahead. I'm sorry, Timothy.
No, I was just going to go to the point about it being expensive of training. Training may be expensive, but your reputation is even more expensive, especially if it's tarnished.
Yes.
When it comes down to patients coming to look at your overall reviews online, this information is available to the public. And you don't want patients saying, I don't want to go to that hospital because they're going to kill me, which is generally what happens, at the end of the day, when it comes down to them not wanting to go to one hospital over another. It's your reputation on the line. And if we're talking about a few $1,000s of training that may be expensive in the forefront, but it's going to save lives down the road and ultimately your overall reputation, I think that's a cost that's worth looking into for your organization.
Absolutely. That's that full feedback mechanism, right? It is your quality analytics, what needs to be trained, identifying that there's risk, getting them trained, closing the gaps, closing the loops. It's that audit that I did, that was essentially a risk assessment. What is their risk of in obtaining the certificate? And obviously the risk of not passing the audit was pretty high. They didn't do anything about it.
Well, we're going to talk next month about proactive versus reactive, but
that's true. I'll try to stay within scope.
It just blows my mind. I mean, how hospitals and healthcare organizations don't have a well-known risk register that they are reevaluating on an ongoing basis. It blows my mind.
And Gary, we're talking about healthcare systems broadly. Some have this, some are working it out. But for those that know, if it's hitting something on the inside of you, like we might need to reevaluate, or you're feeling that uneasiness, that's who we're focusing on. That's who we're looking at. Obviously, there's conversations that are going on. Rob spoke about it earlier about the ability to create a shared accountability for your organization. So if you sense that there's something going on, 9 times out of 10 there is a problem. I think it's time to start to wake up to that as healthcare leaders and executives to say, what do we need to do to ensure that our patients are safe, to ensure that our employees are safe as well, and that we're doing the best to create a safe environment for all.
I agree, because it's that continuous nonstop cycle of there's assessing and improving, assessing and improving, assessing and improving.
That's tough to do manually, guys. It's
impossible to do manually. We work in our company with some of the most seasoned people in this space in the country. And actually we've worked internationally with people in this space. And we know there's both empirically, and just actual fact that it is impossible to be universally successful with people-driven processes. There's operating there's system, or every organization, there's ISO, ASQ, NAHQ, there's, you name it, they will say the same thing. People-driven processes are dangerous to process outcomes. You can't do it. There's
But it's interesting, like organizations are well committed, like to Midas. I know you're very familiar with an organization that's very committed to Midas. And when I evaluate what they're using the system for, one, they wanted to have an automated system so incidents can get reported. However, the process is very dependent on the bedside staff learning how to do things and having to do it the right way for it to actually work, which wastes a lot of time. Right, we've established that in the past, that it wastes a lot of time, and then it stops there. So then the data then may be aggregated, or, up into the group, knowing what all the incidents were reported, but there is no connection back to, well, did you evaluate those incidents? Based on your evaluation, did you establish action? None of that exists in that system.
No.
How can we continue as a healthcare system in America or around the world and allow for those disconnects? I mean, things are getting more complex.
They are, and we are losing resources. Our most valuable, and I hate to call people a resource because people are so much more than a resource, but there's our top most important, there's unmeasurable resource is the people caring for our patients.
They don't have time for this.
And they don't have time for this. I worked on an efficiency project, there's about 6 years ago. There's to remove as many tasks from nursing as possible. And one of the proposals from the CMO CNO was for me to figure out how to make sure that nurses didn't have to respond to call-outs, that nurses didn't have to pass trays, that nurses didn't have to, right? And they had this list of things that your LPN or your CNA or your patient care tech, they should be doing those tasks so that nursing can focus on medications, assessments, in care coordination. And we're so worried about a nurse spending a minute answering a call light, but we're not worried about a nurse spending 20 minutes figuring out how to document an incident that there's no follow-up on. That doesn't make sense to me. We're focusing on the wrong things. Let nurses be nurses. Let nurses respond to patients as the nurse decides to respond to patients. Stop being so prescriptive with that. Allow them to do their job by keeping them at bedside so that they don't have to spend 20 minutes documenting an incident. Which I could vent about that for a very long time. We need to create smart systems, and Aperitisoft Healthcare is a smart system. You can tell quality and risk everything that you need to inside of 1, 2, or maybe 4 minutes if it's a big situation. And you're spending the rest of your time caring for the people that you signed up to care for. Right. You're doing what's the core of your role, not there's sitting in front of a computer the whole time. We already spend a lot of time in Epic and Cerner, right? There's no reason to add more time away from bedside.
Right.
And
agreed.
And we know, again, that feedback loop, if we collect risk data and we move it through quality and we go back around, we know.
Going back to your slide in the live show, I don't know if you can pull it up here, Rob.
I don't know. I may be able to. I can.
Yeah. So it gets back to the concepts of if you don't have the right systems, if you don't have the mindset to merge and to synergize, right, you're not going to get that continuous monitoring that would have prevented the incident of the month where a hospital was an A rating and next thing you know, they're dealing with sanctions. You now have a seamless ability to address adverse events or incidents in the hospital, which allows for it to be more quickly reported and hopefully get you ahead of the curve before bad things happen.
Agreed.
And then we were talking about data integrity here, by, us managing beyond the bedside and looking at the business and the data that's being being handled. If you got a system that can look at all of those things in one place, now you've got a secure environment for the data that is being utilized as well. It really makes sense that the healthcare community today begin to think outside the box. Seem to be an environment right now. There's a movement, right, to be out of box thinking, to bring about change, real change, revolutionary change that is going to improve patient outcomes. Because the reality is, since COVID-19, we don't have the staff in hospitals like we used to.
And statistics show that we won't. We keep projecting greater and greater shortages of doctors and nurses. And in order to maintain patient care, we need to remove any quality gap there's in our processes so that we can actually care for the patient. Yeah. Whether that be time documenting or whether that be there's having things go wrong in their day because we haven't optimized our processes. There's through risk assessment, through compliance assessment, there's through just performance assessment, right? I want to evaluate a process. You can put that into Aperitisoft Healthcare. And you can just do a process evaluation, decide what is high value, what is low value, and then start closing those gaps and removing low value items or enhancing those low value items to high value items. And there's really making smart operational decisions within your organization. And we just don't prioritize that. I find that we talk about it and we stress about it and we hire consultants and we write papers and we go on the news and we talk about the fact that we have no staff and no time at bedside. And we're going to do really smart things about that. We're going to allow virtual nurses. We're going to get a robot that somebody can drive around so that there's an iPad. And that is who's going to do your discharge education. That is who's going to make sure that you're prepared to leave the hospital and not come back and see us.
Yeah.
And you're going to be able to stay well at home.
And let's talk about the discharge aspect, because when quality and risk aren't working together, you have incidents like I've shared with you with a family member of mine, a 90-year-old man who was sent to the hospital because he had pneumonia. Now, we knew 7 years ago that he was having trouble and sometimes aspirating food or drink because of a lot of the things that happened post a heart attack in the hospital. Same hospital, by the way, that took actions and put pressure on the family to take actions that, in my opinion, were actually hurting him, not helping him. So they are, again, based on quality metrics, they were driving certain things home, but yet creating risk. It then led to him returning now, where he was forced to have a trach, which now had affected his ability to swallow, which then leads to 7 years later, him aspirating some food, ending up with pneumonia. And now what do they say? Well, you're 90 years old. You're aspirating food. We can't let you leave the hospital with orders to go back to an assisted living facility. You have to be on a feeding tube or in your nose or in your stomach, unless you go on hospice. So then they're badgering him about rethinking his DNR and rethinking his end of life decisions over a pneumonia situation. It's outrageous. And I'll let you guys comment on that, but I think it's quality driving metrics to get certain things done rather than thinking about the risk they're putting the patient in.
And it's a lack of understanding of what those quality metrics are, what those quality metrics mean, the documentation requirements about it, not to trivialize it to that point. But if that's what they're worried about it, there's most of that, if they're worried about quality metrics, is in their documentation. And
it's all Medicare, Medicaid. That's what they're worried about.
It is. And if they document that appropriately, there's services can still be offered, support can still be offered while respecting patient rights. Because doesn't matter there's how old he is, or there's what his clinical condition is. If he's of sound mind and or his proxies are making informed decisions, it is their right. There's to dictate the care. It is not for the hospital to force something on somebody. There's because of a misunderstanding of quality metrics. It is not okay for the hospital to force something on because they believe that that's what should happen.
Yeah.
To me, that is an incident in a patient complaint or a patient grievance that needs to be filed. And again, that feedback mechanism, we have an actual risk. We have a patient complaint. We understand that we did a bad job with education. We did a bad job with transitional care management. There's in discharge planning. There's in life planning. And we need to do better. So the incident goes in through saying that, hey, patient complaint, family complaint, quality takes over and improves the process. We get the right training in place. We get the right policies in place. We get people to understand patient right laws. We get people to understand the quality metrics that they are citing as the reason that they are forcing these things onto a human. And again, when we're siloed, we don't put those pieces together. We just see, oh, we have quality over here. It doesn't matter if we're doing something else over here.
I don't know how long medical records are kept with many of these patients, but
depends on the state.
The exact same hospital. Same hospital did a barium, I think they call it barium swallow
barium
test.
Study, yep.
Yeah, and he failed before. 7 years ago, and 7 years later, he eventually got pneumonia. Probably, if you look at it from a risk perspective, he's got another 7 years, 5 to 7 years before it will happen again. Probabilistically. It didn't get any worse. It's about the same. So if that's the case and he's 90, what's the probability he's going to live another 5 years? Now, it would be real high. He would be losing his life sooner if you put him on a feeding tube. So shouldn't you think that you would go to the family and say, look, you got 3 options, right? If you're worried about him getting pneumonia again, we got to transition him to being fed another way. It can't be orally, right? But, he's gone this long before having pneumonia. If he wants to continue to eat by mouth, we're going to recommend that you get some therapy. You get some, there are some different treatments out there that might be able to improve his swallowing.
We'll get you set up with an SLP,
something, right?
Yeah.
So,
I just really think that as a healthcare system, using synergistic quality and risk, we could do a much better job of making sure that patient choice, family choice is respected, and that our clinical providers at the bedside understand those choices that they have. They understand how to measure there's patient risk. They understand how to respect patient rights. And
so this what you're saying is that this synergy can avoid the grievances, can avoid the complaints, because you're weighing the facts. You're not just saying, look, I've got to meet a certain metric so to Medicare, Medicaid, and I got to get in the hospice person. I got to bring that person in because of these triggers, blah, 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 blah. They're looking at the patient and looking at the risk to how they're exiting the patient from the hospital.
Yes.
And thinking it through. And it's that balancing act that is so important to make a difference in the level of care and the experience that patients have in these organizations.
So important.
Absolutely.
I love what you said. It's a balancing act. It is a balancing act.
Yeah.
And when you have those full feedback loop closure mechanisms between the functions of healthcare operations, that should be the foundation of that should be quality, risk, and compliance. When everybody fully understands those, your incidence, your risk goes down.
Mm-hmm.
Yeah. Yeah. Now, that example of my family member might be an extreme one, but it is an example, and they're happening all the time.
Oh, yeah. And I wouldn't.
For sure.
Yep. It happens all the time. I see incidents like that way too frequently.
I mean, we go back, this is the same hospital, right? So this is obviously a cultural thing. We've talked about culture before, Timothy,
Mm-hmm.
and a cultural thing. The original thing was that he was in a coma for a few weeks after the heart attack. And when he was starting to come out, he was starting to breathe over the breathing tube. But by their protocols, again, I don't know if this was quality or risk that did this, because the cardiologists and others felt like, just take the tube out, right? His heart sounds fine. He's breathing over it. Just take the tube out. They put pressure on the family to put a trach in. So maybe you guys can clarify, what was the pressure? What were they trying to manage to that would mean you had to put a trach in?
So from a quality perspective, you want the tube out, of the mouth. There's the endotracheal tube out as fast as possible. There's your prognosis, the longer it's in, goes down. Yeah. There's your chance of things like there's oral thrush from a small scale, or from a large scale ventilator-acquired pneumonia, which is a hospital-acquired condition. There's an equality metric.
Okay, so that's a good reason to get it out.
You want that out, because then, of course, the prognosis goes down. Yeah. But I would be interested to know why they went from, hey, he's breathing over the vent. I turned him to CPAP and he was pulling his own just fine, great tidal volumes. He's satting fine on room air, we're good, to, well, let's immediately throw a trach in. So you do want a trach if he's not able to protect his own airway. So I would be very interested to find out why they went right there.
Yeah. And I'm not a doctor. I don't know what was in the notes, but I do know what the doctors were telling us.
I would say, but the biggest quality gap that I see in this process is a lack of communication and education, which is a huge issue when it comes to the patient outcomes after they leave the hospital. And there's a sense of frustration, annoyance, there's miscommunication, or there's sometimes a sense of grief. There's from not understanding why somebody did something. There may be a valid reason. Based on what you just told me, I can't pinpoint a reason. And I was an ICU nurse. I was a transplant nurse. My life was running a vent, right? So what you told me was, it sounds like he was ready to fly on his own.
Yeah.
So I don't know why the tube went in.
Well, I mean, I think today, particularly in the after show, we've made it quite clear, right? Risk and quality have to communicate. They have to be. Absolutely. They have to work with one another. Two, to make that happen, think about having systems like Aperitisoft that will allow you to look at all angles of how you're managing risk and quality in your organization, and have it available for all to see that are in that process string, so that feedback loops are instantaneous and you having communication real time on what's happening. Also, when it comes to taking action, we need to make sure that you've got past due dates and notifications going out to individuals that this has yet to be done, and that oversight knows that it's past due.
Yeah, line of sight into the quality of your organization.
Yeah. And can make sure things are getting done, or have a conversation, why isn't it getting done, and then make an adjustment to the due dates appropriately.
Yep.
So that, everything's being managed and documented. The other thing too, when you're dealing with the action planning side in Aperitisoft, every action you take, if you're changing due dates, whatever, are all being logged in the journal. So an auditor comes in, they're going to see, well, okay, I see you changed the due date. Why did you do that? You can actually put in an explanation right in the system. Due date changed because.
Auditors love that.
Yeah, right. So everything is documented. Everything is in front of you. It makes a big difference in making this stuff work for the benefit of the patient, but more importantly, to start saving some of this poor quality costs that are out there. you know, and once you can get to see it come down and it consistently comes down, all that capital is freed up for the hospital to expand and do more. And that's what we're trying to say.
It seems so simple. It
It sure
really
does,
does.
doesn't it?
It does. It's just, you say it and it's just baffles you as to how the hospitals in our country keep doing the same thing and not making any material change.
Now, next time, guys, when we're talking about proactive versus reactive, let's think outside of just hospitals, maybe long-term care or Donate Life. Let's think into some other healthcare organizations and, you know, how those, that concepts would apply to them. So,
Agreed.
At that, I think we've pretty much wrapped up the after show. What you guys say? And what do we close on here, Rob? What can we share with them or give a last word, if you don't mind?
Yeah. Just to reiterate what we are talking about, we can't keep doing the same things over and over again, and maybe at most adding band-aids and expecting a major change in result. We see healthcare spiraling in a negative direction, and our current operating systems, whether it be there's Q-Pulse or Aldatics, are just not cutting it. We need a more innovative, intelligent solution that works in healthcare processes like Aperitisoft Healthcare. We are looking forward to supporting that change so that we can watch our country turn around and start doing better.
Well, everybody, we thank you again for joining us for the after show. Please like, share, do all the stuff you have to do on social media to let people know that you're supporting this podcast. We do appreciate it. And we'll see you next time where we're going to talk about proactive versus reactive quality and risk. So we'll meet you then. We'll see you right here on the 26th of February. Until then, bye all.